lovely to speak to you. My name is Dominic Hegarty. I'm a pain consultant in pain management and neuromodulation. And I'm looking just very briefly to have a brief discussion today about the context of Covid-19 and in particular about the implications going forward from a rehabilitation perspective and what we might try and expect both for patients who have chronic pain already and for those individuals who may develop new pain and what we need to think about going forward. There's been an awful lot written about this topic to date, and I suppose we're very much in the early phase of trying to work out the acute impacts, and a lot of our colleagues, both pain-wise, anaesthetists, surgeons, etc., are all having to deal with this on a day-to-day basis in the intensive care setting. And we know that this global pandemic is affecting, at this stage, in 2020 and mid-2020, over 7.5 million people globally. And when we consider that we know 1 in 5 individuals develop chronic pain over a period of time, we now have to deal with this new group of individuals who are going to suddenly arrive potentially into pain clinics going forward. And we need to work out how we're going to manage them and what we need to do about it. Despite this, we're not quite sure what to expect. How are things going to work out? What will be the symptoms that an individual who developed COVID-19 and either was admitted to an intensive care setting or perhaps unfortunately didn't have to get into intensive care, but still suffered quite a lot of the symptoms during that period of time. And quite clearly, these individuals are not settling down as well as they might have at this point in time. So therefore, the key really is going forward from an early planning point of view. How do we ensure that we get the right multidisciplinary team in place to promote both the physical well-being, the psychological well-being, and ultimately take down the pain aspect that we know these individuals are going to discuss. Recently and just presently in the British Journal of Anaesthesia, there's a very good review coming from Harriet Kemp's work in London with other colleagues looking around this area itself. So hopefully that will contribute a little bit in due course as well. I suppose the second question we need to look at here is, what do we understand about chronic pain in the COVID-19 cohort? As I said, there's going to be an increase in the numbers of patients that get cases. The ICU setting traditionally has always generated chronic pain patients, even though we mightn't like it. About 17 to 20% of individuals who go through intensive care actually end up with chronic pain condition. And now we're going to absolutely inject a very large cohort of individuals who we didn't predict, who we had no time to build up knowledge about or anticipate that they were coming. And we have to deal with these as they come immediately into mainstream. So we're always going to have a very big risk no matter when this happens. The sheer volume has already put the healthcare services right to the pin of their collars. It's making it really difficult for them to manage. And now we have to manage them not only going forward, as new cases come in as well. So there's a very big issue. Traditionally in the intensive care setting, we've always recognised that there's an acquired weakness following intensive care, that individuals have motor weaknesses, muscle atrophy. This is all well documented, and as I mentioned, 25% of individuals may have some of these symptoms when you actually look at the literature. There's also a sensory component to this, and perhaps that's going to be something we're going to have to look at a little bit more carefully. The second cohort that is going to cause some problems for us in the pain department is the sudden onset of individuals who are otherwise fit and well. Individuals perhaps much younger than we would normally expect to see in a chronic pain clinic, who were active, who were fully employed, doing lots of sports, etc., who were set back by this completed condition and were basically still trying to recover from it. What's the consequences from a pain point of view on them, given that we are beginning to see some symptoms coming that we all recognise? In fact, the type of symptoms have been documented in April of 2020 by Lovell's team, and they're words and languages that we understand. Weaknesses, myalgia, arthritic pains, headaches, insomnia, sleeping difficulties. That almost paints the perfect picture of a chronic pain patient himself. If you tie that in then to other painful para-infection and neurology diseases such as say Guillain-Barré's, for example, which we know a lot about and we know the consequences of itself, and you say it replicates that begins to give us a sense of what's coming in terms of what we need to manage going forward. Undoubtedly, neuropathic features are a big aspect of all these patients. Paresthesia, pins and needles, hot and cold sensations are all very normal. So, again, that's very much talking the language of a chronic pain patient and something that, as chronic pain physicians, we'd be very, very committed to. This also then brings on board where is the source of the pain coming from? We definitely understand there's a central driving factor and there's a peripheral driving factor. And certainly all the reports are beginning to capture these areas very, very clearly itself. So it's not surprising that we're going to have to put in mechanisms that deal with long-term management, not just quick fixes that will have to be put in place, possibly over multiple different areas depending on what the key aspect may be. For example, if an individual presents with cardiac issues, we have to be able to source them and manage cardiac components, respiratory, diabetic, etc. So it's all very important to tie in the symptoms to the original disease that these individuals have. What's interesting at the moment is the mechanism whereby this pain may in fact be generated from. Now, looking at the literature at this point, it's not quite crystal clear. As I've mentioned, central sensitization and peripheral sensitization are features. You could have potentially looked at that as an example. Some areas that are very interesting at the moment are the concept of having angiotensin type 2 mechanisms of converting enzyme involved itself. This was related to the SARS infection some years back. It seems to be a model that would match the muscle pain and the neuropathic pain as simultaneously within the same group themselves. Right now, we don't know. Right now, we understand that there's some form of polyneuritis is going to be involved, and the consequences of this are going to be interesting to see how we can manage going forward. So we really do need to stay on top of this, and I think only with good clinical data will we begin to see patterns and hopefully be able to identify ways and techniques of earmarking individuals who are at higher risk from an earlier perspective and manage them. In terms of rehabilitation, which was one of the key features at the moment for individuals who have the condition, some of these individuals may have been 6 or 9 months now since their diagnosis and ultimately since their recovery, but we're not quite clear how to do that. In Wuhan at the moment, and from our colleagues in Italy, Lee's work in Italy in 2020 have already begun to monitor their outcome. And they're beginning to see there's a whole group of symptoms that can be associated with the rehabilitation phase. Certainly raised levels of anxiety, poor sleeping patterns, fatigue, exercise levels that are not as high as they were before, and concentration and memory have been affected. If you listed that out at the moment, people might say that reminds us very much of fibromyalgia and the fibromyalgia fog. And I suppose in some respects it's the same kind of category that we're looking at, but we can't just classify it all in the same element itself. We all know how difficult fibromyalgia is as a condition to manage, but I don't think we should be looking too beyond that at this point. And ultimately, I suppose, understanding the condition, interpreting it properly, may lead us on to how to rehabilitate properly. But at the moment, we have an issue. As I've pointed out, there are some weaknesses. I suppose traditionally when we talk about rehabilitation, we speak about, say, cardiac rehabilitation, neurology or maybe stroke rehabilitation programs, and maybe even a pain management program would be seen as a rehabilitation element. But right now, how do we define a COVID rehabilitation program? There are so many subsections within that condition that needs to be looked at. We probably have to really drill and work our way through each of the components and then build a program that's going to match it. I would contend that the pain services and pain physicians are one of the key groups in this because we're used to collaborating with different type teams. And we may need to get the respiratory team and the cardiology team working with the pain team for the foreseeable future to manage these individuals as their symptoms progress. I think pain medicine offers flexibility. It can manage the situations using conservative strategies, fully aware of what can be achieved physically with the individual, combining that with interventional workload, be it localized injections, trigger point injections, ultrasound guided, X-ray guided, etc. So huge array of selection of approaches all under the one umbrella at that point in time. So we do need to look at these. Simultaneously, we need to look at what we would regard as good outcomes. What is the quality of life that we want to target and at what speed can we expect to achieve it? We know the recovery from this condition for these individuals is quite slow. It is a little bit piecemeal, but we don't understand that. We're not experienced enough in all those areas just yet to be able to predict for our patients and our individuals when they join us as to where they're actually going to go. I suppose in the long term then, the clinical demands and the challenge is really there right in front of us at the moment. I think we need to be fully alert of the problems that are coming, try and build it into it, try and gain an acceptance in the medical community and the healthcare community that there isn't going to be a single fix to all of this. We need to be able to manage things in conjunction with colleagues, but we will need the resources, because if one can expect this flood of numbers, just like the original infection came out in the first place, we need to be able to accommodate these individuals in a timely fashion. But that needs to be added onto the already busy services that we have in place, the already busy and overloaded services that many hospitals and many healthcare systems are struggling to keep up with on board itself. This is a very, very severe and a very big demand for any government in any institute to try and organise at one time. But I think the opportunity lies ahead for us to get the right thinking people around the table so that we can actually target this progress and make sure that going forward, individuals who have chronic pain with COVID-19 really can get the rehabilitation that they need and try and get back into society as quickly as possible. We need to act on this now and learn from it. Who knows when the next pandemic is going to come? Who knows how quickly we need to adapt in the future? But we need to do it, and we need to be confident in our skill bases that we can adopt these issues. Undoubtedly, I think we can learn from the COVID pandemic. We can upskill certain elements, and hopefully we'll be able to spread that knowledge back into the chronic pain community as a whole, and so that we can improve everybody's quality of life with the benefit of knowledge and tracking. So thank you for taking the time to catch up on this 10-minute presentation. My name is Dominic Hegarty. I'm a consultant in pain management and neuromodulation, working in University College Cork and the Mater Private in Cork, and clinical director of Pain Relief Ireland. Have a lovely day.